All right, I think we have a quorum, so we will get started. This morning, I'm delighted to introduce Dr. Walters, EB Sipe, who is a board-certified physician in both psychiatry and pediatrics with additional training in gastroenterology. He cares for children with conditions that affect both the gut and the brain, such as chronic pain, as well as for children with dysautonomia, a category of conditions affecting the autonomic nervous system, which controls functions that occur without conscious effort. He provides supplementary counseling and support for effectively managing and coping with complex medical issues. And he also has a private practice in general psychiatry. Today, he will be presenting his insights on how to approach patients with disorders of gut-brain interaction, a topic I know we can all learn a lot from and take back with us to our interactions with patients in clinic. So with that, I will let him take it away. Oh, you're muted.
Thank you. Sorry about that. Yeah, it was thanks for having me. I'm delighted to be here. And it was a long circuitous route to get where I am. I think I finished my training as a PGY 10. So hopefully all that extra perspective can be useful. Um, really, my first training was in pediatric gastroenterology, and I went on to become a psychiatrist. And so the topic today is really less about the doing of approaching disorders of brain-gut interaction and how to have a stance, because I think oftentimes if you can't establish an alliance with patients, with families that actually makes sense to them, then all the other treatments just can never get off the ground. So I have a few disclosures here. One is I'm an advisor to Mahana Therapeutics, which is a digital app for IBS, although this may be past tense soon, but I'll bring that up. I may also discuss some off-label use of mirtazapine, which is Remeron and beta blockers, which I think can often be underutilized and actually incredibly useful in the GI clinic. So kind of just starting with the essentials. Typically, when I use the term disorders of gut-brain interaction, this is what's been for most historically referred to as functional GI disorders. And I think the conception of even speaking about them to patients and amongst ourselves as disorders of gut-brain interaction actually, I think, refers much more to the truth of it, which I think functional contains notions of psychogenic, of non-organic, where I think disorders of gut-brain interaction really create what we're dealing with, which is an entire system that involves peripheral factors going all the way from actually the microbiome of the gut to central processing and cognitive processes. And really, as a gastroenterologist, you must be able to articulate and modify this interaction really from both ends. So that doesn't mean that all of you need to be psychiatrists, but you can't just stop dealing with disorders of gut-brain interaction at the gut and not have some facility with understanding how the brain perceives pain, how it modifies pain, and how to provide psychoeducation. Because oftentimes the treatment of these conditions lies just as much in patients having a comfort and understanding of what they're dealing with as just simply getting rid of symptoms. And I think this goes to the second point is oftentimes the greater part of distress in these conditions for patients and families, if you're working with young people and children, is often from the unworkable attempts to avoid unwanted or uncomfortable experiences versus any particular set of symptoms, right? An example of this I'll talk about later, though, is I'm sure all of you probably, if you haven't encountered, you will, the individual who, may have irritable bowel syndrome and they tend to get bowel urgency when they're stressed out. But when you actually ask the question, have they ever had a bowel accident? No. Do they always make it to a toilet? Yes. But what are they doing? I'm not going out anywhere where there's not a toilet. I'm not going out unless I can be sure. So I'm not going out to movies. I'm not going out to dinner. So what you actually see is the distress is not the GI symptom. It's in the same way an individual with panic attacks may never go out, never cross a bridge and becomes agoraphobic. So too, you can see individuals that have GI symptoms are trying to manage this. It can show up as orthorexia, as excessive limiting of food, um, as a kind of attempt to like become preoccupied with the symptoms to the exclusion of what matters. This is really important because if you can start to shift that attention and look at what they're doing to avoid the symptoms that's not working, oftentimes you can really enhance the quality of life and the functioning with very minimal actual symptom change. And I think that gives us as providers a whole nother aspect of that we can intervene on, right? In other words, suffering equals pain times resistance. Um, this is a metaphor. Often, if you've ever seen a woven finger trap, the way that we oftentimes try to pull out of something we don't want, but the more we become preoccupied with getting out of something, oftentimes the harder it grips us. Okay. So I think the function, hopefully the one thing you take away from this is that patients must have an explanatory framework that is compatible with their experience, right? Because for us as physicians, if we do an MRE, ultrasounds, right, upper GI, endoscopy, normal biopsies, we're reassured. We say, look, we've ruled out all these. We've ruled out inflammatory bowel disease. We've ruled out, we've ruled out autoimmune conditions. We've ruled out an enteropathy. So that's reassuring to us. That's actually incredibly distressing for patients because now what you have, they still have the symptoms. They still have pain. Their body's telling them that something's terribly wrong. Now they don't have an explanation because doctors at the worst are saying there's nothing wrong with you. And that's actually more distressing, right? So it's really important that we have to be in their world of explaining, even if we get negative testing, even if we feel like this is something that doesn't kind of meet our threshold for an inflammatory metabolic malignant condition, they need to be reassured about like, well, how is it that my body is giving me the signals that something's terribly wrong, right? That's where I think we need to have that. And if you can do that, that's very reassuring. And as I mentioned in the past, effective management often involves shifting patient and clinician attention from the primary focus on symptom control. And I'm not saying give up symptom control, but that it's expanding functional capacity and engagement in valued activities, right? Let me give you the example again. If somebody that has a tendency to have maybe IBS with diarrhea, if their symptoms don't change that much, but now they have the confidence to go out to dinner, they have the confidence to go on a date, they're not preoccupied and scanning for bathrooms wherever they go, their life has gotten a lot better, materially a lot better, even if occasional sense of bowel urgency or cramping still there. Okay. So again, there's a lot to these conditions, a lot. And so I'm going to make some assumptions in the background with where you are in your own education and training as gastroenterologists, right? So that includes, I'm going to presume that you can formulate a differential diagnosis for clinical presentations. And that includes the next steps, red flag symptoms, when you do an endoscopy, when you check for a fecal calprotectin, and so on. So I'm not going to go through that because that could take a chunk of time. Also, that you can self-study the FDA-approved medications for irritable bowel syndrome and other disorders of gut-brain interaction and use these under clinical supervision. I may talk about a few things off-label, but there's a lot of that information. And I'm also going to talk a little bit about visceral neurobiology. I think that's critical for providing psychoeducation because that's how patients start to understand how they can have these complex alterations in motility and sensation, even perhaps in the absence of any gross findings. But the more you learn about visceral neurobiology, the enteric nervous system, how it interacts with the central nervous system, the more effective your psychoeducation is going to be and the more effective you're going to be at treating these conditions. Okay, so the first thing is, I think, is just often just creating a framework for these patients when they come in, right? So I often use this cartoon. This is a cartoon of Rene Descartes. I think therefore I am is of fame. But he's closely associated with the philosophy of the mind called dualism, right? This we call it Cartesian dualism. This assumption that mental phenomenon in some respects are non-physical, and that the mind and the body are somehow metaphysically distinct, even if they interact, right? And so in the area of modern neuroscience, we may think we're beyond this, but it's still a powerful bias in medicine, and it's still a powerful bias in the language that our patients come in with, right? I mean, how many of you have heard this distinction, right? Are symptoms organic or are they psychogenic? As if it's one or the other. Like, and I think this is a really problematic, and sometimes this gets sort of like, and that's why I tend to try to shift from functional disorders to disorders of gut-brain interaction, because functional tends to carry the label of psychogenic or it's non-organic. And I think this is very problematic because what this gets translated to in the clinical world for our patients is some things it's either real, it's real pain, it's real symptoms, or these symptoms aren't real, or they're somehow in my head, right? And this is if you're in this dualistic model, particularly with whether you're in it as a provider or a patient's in it, you're really in a double bind, right? Because what happens is in this model, you can't win, right? So organic or it's medical is real, right? Then the patient will often say, this isn't my fault. And it's the doctor's job to fix me. You need to fix me. There's no behavioral or psychological intervention I can do. Tell me what the problem is, fix it, right? Of course, if they're on the other side of that, if it's, functional and they're hearing it's in my head or not real, they're either going to take it, this is my fault, or you're telling me I'm doing it to myself, or you're telling me I'm going to make it up, or you're saying there's nothing you can do about it. And that double bind, I think, is one of the things you need to be attentive to very, very early on in these visits. And so a metaphor that I use that I find that's very, very effective is sort of the metaphor of a fire, kind of a fire alarm, right? Most people kind of get the sense that like pain is like the body's fire alarm, right? The traditional model is we have pain and it hurts where the problem is. That's the default. People come in, I have a problem where my pain is. And so if we think about like how a fire alarm might work, and I use this metaphor with patients, how a fire alarm might work. You're in a building, the fire alarm goes off, it's distressing, everyone runs out of the building. The fire department comes up, they run up the stairs, they look at the fourth floor where the fire alarm's triggering. They don't find a fire. Right. Everyone back in the building, we don't see a fire. It happens the next day. Everyone clears out of the building, no one can work, everything's disrupted, the fire department comes back again. They look again, right? Now, in that metaphor, that's like us doing repeated testing. Now, I think we can kind of viscerally get as physicians, if somebody in the building said, hey, keep looking, there must be a fire because the fire alarm's going off. That would be kind of insane, right? And I think that's the position oftentimes we as physicians get when we have families that are like, keep testing, there's something wrong here. But I think we could also it would be very bizarre if the fire department said, you don't need to leave the building, there's not really an alarm going off. And that's the situation that patients often feel like they're in. They get, in attempts to reassure there's nothing wrong with you, they're being told that the alarm's not actually going off, that it's somehow not problematic. And so rather than getting in an argument about, is there a fire, we shift the problem to the alarm's going off, it's really distressing. But instead of calling the fire department, maybe we call an electrician. Maybe there's a short circuit in the system. The problem isn't where the alarm says the problem is, right? The problem is in the alarm system itself, right? That starts to shift the model into, now we're not trying to find the problem, but we can start to address the gut-brain interaction. And I think that's a very useful metaphor because intuitively people can get that, right? Many of you, the sort of the evolution of functional disorders really is the sort of criteria for the diagnosis has come with the Rome group, and they're now on Rome 4. They're probably coming up on Rome 5. But there's a couple of volumes actually of disorders of gut-brain interaction, which is a great resource because actually there's very specific criteria for these, for IBS alternating, IBS mixed type, postprandial distress syndrome, centrally mediated abdominal pain syndrome. So there's actually diagnoses for these. This is very useful because I think oftentimes giving individuals diagnoses, right? We want to be careful like about labels, but they can be very useful because a diagnosis can give something that's real. A lot of these patients, part of this the feeling of it's not real is they get hand-waving responses from their primary care doctors, maybe sometimes even from gastroenterologists. Oh, I think you have maybe a functional disorder, or maybe I don't know, it's IBS. They're getting what it's not. You don't have IBD, right? You don't have an ulcer, but they're not actually hearing what it is. And sometimes just labeling something, oh, that's my diagnosis, that's what I have. It gives it a sense of realness, right? That's useful. Now, I'm not going to kind of go too deeply into this model of, but this is an example of a conceptual model. But really, it's just showing like this is just even if we take the model of IBS, right? That it's clearly not psychological. It's clearly not just fun, like locally organic, but that there's early life experiences that includes early life stress influencing the brain and the gut. There's um, bidirectionality of the autonomic nervous system, of the hypothalamic pituitary axis. There's, you know, physiology that's bidirectional. So again, you kind of just get a sense like all of this is what's behind something. And I think holding the complexity of this and dropping into aspects of this is what starts to help people get an explanatory model that it's not just pain here, wire to the brain says there's a problem. That's the somatic model of pain. But wow, this is like a complex network at multiple levels. And the more complex a network is, people can viscerally, pardon the pun, understand that the more complexity you have, the more multiple interactions is, there's more opportunities for things to go off or for perceptions to not match, um, sort of perception to not match pathology necessarily. Right. By the way, so again, another metaphor I often will use, right? Because a lot of people this metaphor of like, well, there's a problem there. Keep looking. I must have an ulcer. I must have a lesion. I must have a tumor. There must be inflammation. I tend to like to use the metaphor of uh, phantom limb syndrome, which actually may be functionally somewhat the case, but you know, I can most not people mostly have heard this. It's kind of exotic, but it's in the press. But the value of relaying something like phantom limb syndrome is, look, we know without a shadow of a doubt that individuals can actually feel pain in parts of their body that don't even exist anymore. This has been observed since the Civil War. This is not psychological. This is not psychosomatic. It has to do with how the brain can make a model of pain and can keep generating that even in the absence of tissue injury that's ongoing, right? On the other hand, we know that there's individuals that can do feats of seemingly putting, you know, generating tissue injury, putting wires through their body without feeling pain. We know that we can do, there are individuals who have undergone general surgery under hypnosis. So the mind also has the capacity, and the brain also has the capacity to not perceive pain or reduce pain even in the presence of undeniable tissue injury, right? So by presenting the extremes, neither of which your patient is at, it starts to create some space of not where's the problem, but how do we start moving how your brain is perceiving pain, how your GI, so more from the left hand to the right hand side, right? And again, we're breaking apart that metaphor of a billiard ball notion where tissue injury causes pain. Very simple, right? So if I have pain, I have a problem where the pain is. So if you just do this, you already, I think, are going to be way ahead in counseling and having an alliance with your patients, right? So what are some action steps here? Well, first, it's always validating the patient distress while challenging their simplistic explanatory illness models, right? So the distress is real, but let's move you from like looking for a fire, like we've already done that, to how do we start to understand perhaps there's actually something in perception, sensation, a short circuit that we want to address. And again, using metaphors to shift the frame from mind-body dualism to a sense of integrated complexity, right? And then again, I think offering specific diagnoses, right? Getting to know the Rome criteria. So if you've got somebody that's got a disorder of gut-brain interaction, take the time to tell them what you think the diagnosis is, not just all the rule outs that you've been doing. Okay. And again, this is where becoming very aware of the diagnosis of exclusion, right? And I think this is unfortunately a lot of individuals they're only being discussed, they're only being talked about postprandial distress, functional dyspepsia, irritable bowel syndrome after they've had labs, endoscopies, right? Imaging. And I think that's really difficult because if you're waiting until you've had all these negative studies and then it becomes a diagnosis of exclusion, you've reinforced this notion of like, we're going to keep looking for the fire. And then at the end, there can be a sense of like, well, you're fine. Now go see a psychologist, see a psychiatrist. And then they do it all over again. They don't trust you. So it's really important to do the metaphors first so that you're prepping people to say, look, there's a few things we may want to check out. There's a few more lab studies I want to get. Given what you're telling me, I'm suspecting they're probably going to come back unrevealing. So here's why we're doing them, but we really want to focus on how you're relating to this pain. So not waiting and really not viewing these as a diagnosis of exclusion. They belong on your differential, with like where they belong high in the differential and you're treating them and then you're doing rule outs or other studies simultaneously, not getting to this at the end. Okay. So the next thing I think that's really, really useful is like, okay, you've broken down this mind-body dualism. Then someone's like, well, what's going on with me? And that's where I think psychoeducation is really useful. This is not necessarily therapy, but you're providing education about a condition that gives somebody a way of relating to their own experience more powerfully, right? And I find that oftentimes what's interesting is sometimes giving more information. We're always taught be really simple, give it in language that patients can understand. And that's usually the case. But with psychoeducation, oftentimes it's not a bad thing if you give it in more complexity and more detail than patients can understand, because what they're left with is, I didn't get every single thing you said about the enteric nervous system. But number one, I got that, okay, I can see this is really complex. So now I can see how maybe these symptoms do make sense and it's not just you're missing something. It also helps create alliance that, oh, you know what you're talking about. You're not just brushing me off, but you're somebody that understands how the gut works. And now I can actually trust you a bit more. When I do psychoeducation with these disorders, I typically think it's best to start bottom up, in a sense, go from peripheral to central. Why? Because it basically is helping, you're starting with what might occur as more medical first. So when you get to the more central pieces that would be viewed as psychological, that's happening on top of what is already right? So I often will talk about just the micro, and I'm going to go very fast here. So I'm just giving you the flavor of this. I'm not expecting anyone to kind of like try to write this down, right? This is kind of giving you a flavor of like how this might work in a clinic, because I might take a whole hour to go through this with a patient. But I usually just start with the microenvironment, right? So we actually know that like the function of your gut, the immune system, your diet, bile acids, the microbiome, your particular genetics, the endocrine system, like the enterochromaffin cells. There's multiple things going on at the surface level of the gut that affects how nerves perceive pain, perceive sensation, and regulate motility, right? And from there, we've got multiple different kinds of nerve endings that receive um, signals from the gut, transmit it through the spinal cord and into various parts of the brain, right? And in fact, we have at least 4 kinds of receptors for visceral sensation. There's the vagal mechanoreceptors. There's the low threshold spinal afferents. Those are the ones that kind of, when you feel your gut kind of churning a little bit. There's the high threshold. These are the ones that like get activated when you have like an obstruction that feel pain. And then there's the silent spinal afferents, which are really important because these are the ones that do not transmit a signal except when there's injury or inflammation. So these don't transduce a signal unless there's some type of inflammatory mediator, right? Very relevant because I think this tends to already explain how do we start to, this is what happens in tenesmus, for example, or when you have an enteric infection. And probably these underlie when we start to see post-infectious IBS or other post-infectious conditions where you have these silent afferents that for some reason turn on, or you have an environment of microinflammation that is now creating this visceral hypersensitivity, right? And so just as a reminder, so there's this spectrum where oftentimes IBS, for example, you can have it generated on the left-hand side, you can see that peripheral factors can generate afferent sensitivity, hypersensitivity. In the same way, after a sunburn or a thermal burn, your skin may feel tepid water may feel intensely scalding. In the same way, that's how we can think of the afferent excitation that can happen in disorders of brain-gut interaction, kind of IBS being the canonical version of that. And over time, right? Anxiety, attentional factors, preoccupation with pain, various stresses can start to basically sensitize the central nervous system to peripheral pain to the degree that which oftentimes then the filtering of noxious stimuli coming up. So now you've got, at some version, you can have a peripheral factors, but that can also lead to, that can be magnified by a loss of filtering and sensitization centrally, right? And there can be a whole spectrum here. This was just, I won't go deep into this, but what's interesting about this is you can actually see how this interacts. This was a functional MRI for individuals with IBS versus normal patients. And what was interesting about it is when you look at basically lateral structures that are kind of like perceiving intensity of pain and central structures, which are more of the affective, emotional component, you see individuals with IBS, right? They have more pain signals getting to the somatosensory cortex from below, but simultaneously there's a higher emotional response to it, right? So it's not either or, it's not psychological, it's not psychological, right? It's not, there's peripheral factors, but not exclusively, right? Again, I know this is a lot, but this is just to give you a sense of how this actually is helpful for patients, right? On the left-hand side, the same thing. We often see that, like, what we don't take for granted is that there's sensory filtering that's going on, right? So if we really, there's constantly movement in our gut, right? I mean, if somebody doesn't have bowel sounds for a minute, we usually consider that hypoactive bowel sounds, but we don't go around for most of our life aware of the bowel sounds, the borborygmus that's happening. That's where that physiologic stimulus often just gets filtered out. It's there, but we don't hear it. You might think of it as an air conditioner running in the background that you don't hear. So typically, it's only salient or noxious stimulus that makes it through to conscious awareness. What we then often see in disorders of gut-brain interaction is that physiologic stimuli make it past that filtering, right? So that's where oftentimes you have individuals where they may have had peripheral pain. Now they're paying more attention to it. They're paying more attention to it. So now more physiologic stimuli are making it through to the brain. And as they pay attention to it, it's those physiologic stimuli are starting to trigger emotional responses, and then it becomes a vicious circle where the more attention goes back to visceral stimuli, the less filtering there is. So now it becomes a vicious circle where you have more attention on a part of the body that's sending back more signals. More attention leads to less filtering, which means it's perceived as more intense, and that becomes a vicious circle. right? Again, not psychogenic. It's a gut-brain interaction, right? So again, for example, peripheral processing. So IBS patients often show increased activity in ascending afferents. There's more pain coming up, whether that's from microinflammation, previous infection, whatever. Then they have altered descending pain modulation of pain input. That's the lack of filtering. There's more pain coming up. And then of the signals coming up, more of it is getting through. And then there's evidence for increased arousal and attention. So then more coming up, more getting through. What's getting through generates more upset, more anxiety, more attention, which brings scanning and tracking back to the gut, which then again increases it in a vicious circle. Okay, so you can see that was like I would really whip through that. But if you can start to get a patient understanding that, it actually gives you some openings to how to address this from lifestyle factors, right? So relying on the complexity of the gastroneurophysiology gives patients a framework that the pain's compatible with their experience. You know, if they can actually hear that, it's like, oh, okay, this is what we're dealing with. Start from the bottom up. I think that basically starts then when you start to talk about like systems like attention, arousal, anxiety, it has it, you're kind of talking now about central nervous system processing rather than, oh, this is something psychological that I'm doing. And again, overdoing it sometimes is important. Even if they can't remember the details, the experience of the complexity of the enteric nervous system and how it interacts with the brain can be validating, and then it reinforces the earlier metaphors, like the fire alarm, you know, the fire versus the short circuit. Okay. Now, so after all that, now how do we bring in stress? Because I think we often see that stress, anxiety clearly is going to be a component in almost all of these disorders of gut-brain interaction. But if you come in and you just say, this is stress, forget it. You've lost people. It's not in your head. Well, one thing, again, I add to the education, this is really important, is if we think about what's the physiology of stress, right? There's usually a cortisol response, right? Well, cortisol, that whole HPA axis is triggered by corticotropin releasing factor. And that leads to, you know, anxiety, arousal, stress in the brain. But there is massive amounts of CRF receptors in the gut, right? Particularly on mast cells. So as I tell my individuals that stress, what we think of stress, not anxiety, but any stress, anything that gives stress in the system has a direct impact on the gut, right? And so, you know, what we often see, particularly individuals that have visceral hyperalgesia, IBS, is that we see mast cells, right? That there's more mast cells in the mucosa. They're degranulating at a higher rate. There's more tryptase, histamine release. So these are, you know, inflammatory mediators, and they're closer to the nerve endings, right? We also see, right, in IBS, that if you take biopsies of individuals that have visceral hyperalgesia, you culture them, and if you actually like do an in vitro preparation, you take the supernatant of these cells, you actually get increased stimulation of enteric nerves, right? So we actually see that there's increased, you know, we're talking about of how these micro-inflammatory mediators that you don't see it under biopsy, right? You certainly don't see it grossly on endoscopy. You don't even see it under like an H&E stain. But there's actually a microenvironment often of inflammation that unmasks some of those silent afferents, right? So then we can start to think about like, okay, actually stress, which we kind of tend to think of as synonymous with anxiety, is actually a physiologic response that has widespread interactions on the peripheral gut mucosal permeability, mucosal transport, immune system, smooth muscle contractility, visceral sensitivity, right? This is another vicious circle. So you can start to see stress isn't just in your head. Stress actually is a pro-inflammatory insult and a functional insult to the gut. Now, of course, if your stress is coming from a preoccupation about your visceral symptoms, it's very easy to see how a vicious circle can get established where stress can perpetuate altered sensitivity, altered motility, symptoms of which makes you stressed, right? So why do I emphasize this? When you emphasize the physiology of stress, again, you're holding that background of not being in a dualistic response, but that stress itself has a um, physiologic component to it, right? So you avoid the pitfalls of mind-body dualism, and then what you're doing is you're prepping. So you're building this set of metaphors so that it enhances the acceptance of behavioral or psychological therapies as part of the medical management of disorders of gut-brain interaction. So you can see the difference between already, you come in, you do all your workup, you do a diagnosis of exclusion, you haven't done any of these metaphors, then somebody's told, don't worry, there's nothing wrong with you, I think you should see a psychologist. You can imagine how well that's going to go, right? They're not going to believe you. They're going to feel like you're stepping right into that sort of invalidating framework versus you've built all this up. You've built the physiology, you've talked about the awareness of brain-gut interactions, and now you've built up a point where now stress itself can create GI inflammation. So now when you talk about stress management, you're actually doing it in a context that's part of the medical management rather than an invalidation or in opposition to medical management. Okay. So the other piece, so there's stress management, but there's another piece here, and that's really addressing avoidance. Okay. And we kind of think about a distinction between pain and suffering, right? And this is not, this is just one conception of pain, but I think it's useful to think about the difference, right? So we can think about pain as any noxious or aversive sensation, right? And to some degree, it's a natural consequence of being an organism with a central nervous system, living in an environment that's not organized around our desire for pleasure, right? I mean, to some degree, to exist is to have to be with some degree of discomfort, right? And quite frankly, like, we don't survive very long without pain. There's actually families that have a genetic, I think it's a potassium receptor, that actually don't feel pain. They don't have nociception. And those individuals die very early. They die of infection. They die of, they have injuries because they have no fear for self-preservation, right? But we can think about suffering as something different. It's the emotional anguish that tends to arise in the presence of pain. It's a consequence of having a mind, of a part of it, of thinking about how do I get out of this? What's wrong with me? Right? And I really like, just sometimes there's a kind of a neural correlate that I like to think about, that that we can even think about pain. Again, as I mentioned earlier, this is a fMRI of hypnotic. It's actually, it wasn't about hypnosis. They were using hypnosis to do the imaging, but they had individuals put their hands on a not damaging, but quite uncomfortably hot plate, right? And so what you saw is, like, in the little sensory homunculus, the hand lit up because that's where the heat was coming from. And then again, these central midline structures that kind of correlated with unpleasantness of a sense of pain. They did a hypnotic intervention to work on, to address the sense of discomfort. And what was really interesting is post-hypnosis, the lateral structures, the somatosensory cortex, was basically just as active, although the midline activity really went down. And that correlated with individuals subjectively saying, well, it feels just as hot, but it's less bothersome, right? So why is this important? Well, because if we start to think about pain and suffering as identical, then the only way to reduce suffering is to reduce pain or discomfort or whatever the symptom is, right? So it locks you into this notion of, like, the only thing, you can only help me if you get my symptoms better, right? And so oftentimes, as I mentioned, but it's not like, one can have a sense of bowel urgency and still go out to a movie, Or one can totally not go out with the same sense of bowel urgency. It's the same symptom, but the suffering is very different in those two situations, right? And so the problem is the most problematic behaviors may be effective in the short term, right? I don't worry about having to go to the bathroom, but in the long term, there might be a disconnection from dating, from school, from work, right? Um, so it's again, it's that notion of the finger trap. And I actually have these in my office. It's my psychiatric practice. This is a really great model of the human mind, right? Underlies not just in GI, but almost anything where what we resist persists. We want to avoid something. We try to get out of it. It grips us tighter. We pay more attention. We put more effort on trying to pull out of this. And yet the more we pull out, the paradox is the less attention we're paying to other aspects of our life, right? So here's some examples of IBS with agoraphobia. I put this in quotes, but I think this is a real thing in the same way as I mentioned this earlier, that you can see individuals that may have a bowel episode, they feel like urgency, they're scanning for a toilet, and then they start to not go to any place that they can't be totally confident that there's a toilet available. We see people they start to oh, activity, working out, it may reduce I feel like that aggravates my symptoms. So now they don't work out, they become deconditioned, they move less. Then now they have suffering related to deconditioning. People may use distracting techniques, scrolling on social media, playing video games, right? To the exclusion of valued activities. So the distraction may work to take their mind off the pain in the short term, but it's also taking their mind and their behaviors off of things that are important. Extended toilet sitting time. I don't know how this is in the adult clinic, but I'm always asking for this with my young people and adolescents. And I see it in some cases when you start to have this hypersensitivity of the rectum. I've seen patients that will sit on, they'll say, I sit on the toilet for a long time, quantify that. Because it's sometimes hours a day. I've seen patients come in and they're literally sitting on a toilet 2-3 hours because they're trying to get rid of that feeling of incomplete evacuation. So their behavior is they're just trying to get rid of the feeling of incomplete evacuation. Of course, that leads to social problems. Social withdrawal, rumination. I should say with this group, I'm talking about psychological rumination, like trying to think how it could be different. Although rumination is often a thing. Food obsessions, restrictions, orthorexia, right? Maybe if I get the right diet to this, I actually saw 2 cases of scurvy in my medical career. Once was a developmentally disabled child when I was in my PEDS residency. The other was at Langley Porter, and it was an individual who was having abdominal pain starting at 11, 12 years old, and his mother kept selectively eliminating food items without acting them back in. By the time he got to us, he was 23. He had a diet of exclusively white bread and beef. And he actually now it wasn't the worst case of scurvy, but to get scurvy in San Francisco really takes something. So that's actually an extreme example of the avoidance of pain actually being worse and causing worse problems than the issue itself. And then again, requests for excessive testing, doctor shopping, we can think of these as attempts to try to get out of, very understandable attempts to get out of pain, but that can kind of drive suffering, right? And so I often talk to patients about the cocktail party of effect, because the paradox is what we attend to, we amplify. So if we put attention on something and pain calls for attention, it gets bigger in our experience, right? But we can't track for something without looking for it. And the thing about our nervous system, if you think about the cocktail party effect, right, is we can stand in a loud room and we can eavesdrop on 5 different conversations around us simply by shifting our attention. We don't have to do anything behaviorally, right? And you're gonna have a very different experience of that party depending on which conversation you're eavesdropping on. But we can only track one conversation at a time. Our nervous system can't attend to everything. And this is one of the things that happens in disorders of gut-brain interaction, is that as attention starts to narrow onto the problematic symptoms, it magnifies those symptoms to the exclusion of other things that matter. So oftentimes, if you're just saying, well, I'll move my attention when the symptoms change, we have to flip that around and say, can we find alternate valued sources of attention, right, that still make a difference? I think I have enough time to do this. So one of the issues kind of exercise I do with individuals, I'm going to do it very quickly. You all can do it along with me, but I'm going to do this very quick. But I'll actually ask people, what do you feel in your finger right now, your right index finger? Okay, usually not much. I'll say, okay, now stare at your index finger. Tell me every single feeling you feel from your finger. Every tingle, every swirl, every pulsation. Okay, now if I did this, by the way, probably about 2/3 of the people here would start to feel their finger tingling. Now, interestingly, I've been doing this for about a decade. My finger is burning right now. It's on fire and it's pulsing. Why? I've done this so many times. I've taken just a benign part of my body. I've created a brain-finger connection. Every time I do this exercise, my finger predictably will be about pulsing. It'll be a little bit distracting to me for the next 3 minutes. Right? So when I do this with families, I build this out a little longer, and you can do this. And they start to realize, wow, I'm having a lot more feeling in my finger. Okay, so we just did that for 2 minutes on a part of your body that's not bothering you, has no pain. What do you think's happening in the central nervous system? For example, if you sit on a toilet for an hour and you worry about feeling this incomplete sensation, and you do this day after day after day, do you think that that might increase the perception of sensations? Yes. See, that's not psychogenic. That's not psychological. It's just how our attentional system works, right? So I find that can be very powerful because it breaks this vicious circle where pain leads to hyperarousal, leads to hypervigilance, like where's the threat, which leads to tracking of pain, which magnifies the pain, right? So this attentional cycle is really, really, right? So example, right? So for example, if you have pain, you sit on excessive toilet sitting, you have more awareness of your already rectal sensation, which is more painful or distressing, which leads to more toilet sitting, right? So that's an example of how this attentional cycle can go. As we say, quite literally in the GI clinic, it's not just to poop or get off the pot, as they say, is very important. And that's the neurologic basis for that. Okay. Also, it's remembering that conditioned responses drive avoidance, right? This is a little measure, like Pavlov actually won the Nobel Prize, I think, in 1904 in medicine for these experiments, right, on classical conditioning. But this is a really important thing to attend to oftentimes in disorders of gut-brain interaction, because there's often a conditioned response that drives avoidance behaviors, right? If you all know the Sauce-Bernays syndrome, really important. Nausea is very, very powerfully conditioned, right? So a noxious sensation can lead to powerful, so if you have norovirus during the incubation period and you have a Sauce-Bernays that night, you may have, diarrhea, vomiting. You're not going to be able to touch that sauce for years. That's how powerful the conditioning is, right? And so we often see this where individuals develop anticipatory anxiety. They see nausea. They have, like, for example, postprandial distress. So from a conditioning standpoint, they're being punished for eating and they're being rewarded for restricting, right? So that's another vicious circle we see, that where food items become associated with a noxious reaction, you get short-term relief, and then it generalizes to a larger category of stimuli, right? So I think the important thing is there's this vicious circle of avoidance where individuals understandably are trying to avoid activities that lead to further distress, right? But the avoidance itself is what's underlying disability, right? And then that's disengagement from valued life activities. So when you start to pull out this, so if you're just waiting for the symptoms to get away, it reinforces this avoidant vicious circle. So this is where thinking about treatment for cure versus treatment for rehabilitation, for building capacities. We want to do what we can to minimize symptoms, right? And then we want to, the symptoms can be a source of attention, distress, but avoidance is often the real problem, right? So this notion of acceptance is not resignation, but it's the willingness to have your experience because you're having it, and what you're already doing is not working, right? It's not resignation. It's not giving up. It's not saying there's nothing more we can do. It's actually saying, look, this attention very understandably on your symptoms, very understandably, by the way the nervous system works, tends to drive the perception of those symptoms. So can we start also having a conversation about what matters? And you don't have to send them to a therapist to do this in your clinic. This is part of the psychoeducation. This is part of actually a treatment alliance, right? Because there's no silver bullet for the disorders of gut-brain interaction. They have to be addressed as an interaction of systems. But when you can separate, okay, there's the symptom, there's the pain, and now let's look at everything you're doing in response to your pain. Is it working? Is it actually taking you to a life that is actually values consistent, what you want to be doing? Or is actually these understandable attempts to get out of pain really causing more distress, right? I just give an example of, I had a young woman in my clinic, and she'd have kind of a bouts of like, sort of as like IBS with constipation. She had these really painful bouts about 4 days out of every month where she'd have constipation, really intense pain, but relatively symptom-free in between. And she said, she was just crying. What if I'm dealing with this for the rest of my life? What if I have to get rid of this? And I had a conversation with her. I said, okay, what if you were dealing with this for the rest of your life? But what you were really dealing with is what you're telling me is 4 days of unwanted symptoms a month and 26 days where you're actually symptom free. What would it be like if you could have those symptoms just for those 4 days, but didn't spend the other 26 days worrying about anticipating what was coming next? And kind of her tears, she was sort of shocked to realize that it wasn't actually the symptoms that was the problem. It was how she was relating to the symptoms during all that period when she wasn't having them, worried about what happened in the past. That was effective treatment. So right there, without changing the symptoms, her relationship, actually, she was like incredibly reassured. It's like, oh, I actually wouldn't want that, but I could be with that. I could be with that for 4 days out of the month, right? Right. So attaining, I'm sorry, we're kind of attaining. So this is where just looking at functional goals, right, is just as important as managing symptoms, and really looking at how do we, symptom reduction isn't the end, but we're really trying to enhance values-based living, right? And at the end of all that, yes, there are a lot of evidence-based psychological strategies for functional GI disorders, for disorders of gut-brain interaction. But I hope you can kind of see that, like, you really, as gastroenterologists, need to set the stage very powerfully inside of explaining gut-brain interactions so that when a reference is made to mindfulness, to cognitive behavioral therapy, to gut-directed hypnosis, they see it inside of the context of effective treatment for these, not the medical doctor punting because there's not a organic condition, right? Let me pause there, and I will just